Yeah, thanks, Stanley, for that kind introduction. It's a real honor to be here to speaking with you, and a pleasure. So I'll jump right into it. I'm going to be completely honest with you. When I finished my oral surgery residency, 2007, I felt pretty comfortable with a lot of oral surgery, with pathology, with orthognathic surgery, with trauma. And even though I had done some cases with a few varied attendings, TMD was the one subject that was still a little bit of a black box to me. Maybe it is for some of you in the audience. So the thing that makes TMD so difficult is that there are multiple layers where things can go wrong. So you've got the complex anatomy, where you can have pathology at different levels, and then you have patients with the mental problems that patients with chronic pain often struggle with. So when I was first was an attending, I found it difficult to focus in on the problem. And so it took some time and experience, like anything else, to make that black box not so black. And so what I want to do for you today is share some of that and make the box not so black for you. So in doing so, TMD is a big area. I want to talk a little bit about the scope of the problem, give an overview of the diagnostic strategies and patient classifications, go over some surgical options. I've got a couple of 2 or 3 surgical cases I'll take you through. Talk a little bit about the non-surgical options in the office-based procedures, and throughout I'll scatter in some of the research we've got going on. So yeah, Stanley mentioned that we operate at the San Francisco VA. We operate as a team generally. We run the service as a team. Rebecca Silva, Shelley Miyazaki, and now Jay Gupta has joined us, and so we all see these patients and manage these patients together, which makes it nice. We have become the de facto TMD center for the VA, and that means we can see a lot of patients, and we see a wide variety. So we've had to develop over the years a way of looking at these patients that creates an effective diagnosis and treatment plan. So it's interesting, Stanley brought up some numbers. Other than lower back pain, TMD is the most common musculoskeletal problem leading to disability. So other than lower back pain, I didn't know that until I looked it up. I think that's pretty amazing. One of the most common reasons people go to the dentist is because of jaw joint pain. And then the current estimate is probably around 4 billion, but that's going to rise because one of the risk factors for getting TMD is age. And we, in the next 40, 50 years, are going to see an explosion of people older than 65. So that means that all of us in this room are going to see more people, more older people with TMD, and having an idea to know how to diagnose and what to do for them will help everybody a great deal. So TMD, temporomandibular disorders, is of course a catch-all phrase. And you can see on this complicated table that I've made blurry on purpose. It includes a lot of stuff, and it's complicated, and the patients are complicated. So what do you do with something that's complicated? So we've got we've got a lot of things to consider, and I think breaking a complicated thing down into these parts is the best way to think about it, and then you can put it together afterwards. So you've got muscles, you've got bones, you've got the articular disc. So I think if you can think about each of those parts individually, then you can come together afterwards and make a diagnosis. So this isn't rocket science, but basically there's 4 parts of the pie. There's the articular disc, the muscle, masseter muscles, temporalis, lateral pterygoid, medial pterygoid, and masseter. There's the bone, the condyle, and the fossa eminence, and then there's others, like what the patient comes with, either chronic pain, psychiatric disease, and whatnot. So we've got to take all that into consideration. And we do that just like everybody else in the room does it with a good history, good clinical exam, and imaging studies when we need it. And so I'll just point out some of the TMJ specific things we look at in the history. So when we're thinking about if a patient has a muscle problem, we want to know if they have a history of clenching or bruxing. We want to know if they have a history of have muscle spasms. When we're thinking about the articular disc, we want to know if they have joint noises. We want to know if they've ever been open locked or closed locked. And then as far as the bone's concerned, is there crepitus when they open and close or when they eat? Does it sound like a bag of rocks in there? Have they ever had any trauma? Do they have any other joints? Do they just have a knee replacement? So degenerative joint disease in another joint. Your TMJ's a joint just like every other one, and it can get degenerative joint disease. And then you want to know if they have chronic pain or any psychiatric illness such as anxiety or depression. And then we go to the clinical exam. You can look at the musculature. So is the musculature hypertrophic? And I asked the residents this earlier, but does anybody used to seeing this X-ray? This is a Panorex, right? So every oral surgeon in the country has one of these machines in their office, and you can take this X-ray. So if you look on the angles here on the inferior border, you can see some hypertrophic bone. That bone growth is stimulated by muscles that are overactive. So it's one clear clue that this patient's overusing their masseter. And then we assess for tenderness to palpation. As far as the disc goes, this is the disc right here in a cadaver specimen. So we want to know about joint noises. We want to know what the maximum size will be. Maximum size of the opening should be about 45 millimeters. If it's not, there's probably a problem with the disc. Does the patient, you stand in front of the patient, watch the patient open and close. If the patient deviates to one side or the other, then that's a clue that the disc might be a problem. I've seen some patients deviate over to one side and deviate to the other before they can finally open. And then timing can be important. Whether it's when they open, whether it's a mid-click or a late click, and give you an idea of what that articular disc is doing. These are all clues. And then crepitus, you can listen, use your stethoscope and listen when they open and close. If it sounds like a bag of rocks, and then you're probably looking at a situation where the disc just isn't there and the patient's functioning going on a bone. And then chronic pain, sometimes chronic pain patients have trigger points that you can identify and treat when you decide to treat them. And now we move on to imaging. So like I said, every oral surgeon has this imaging device in their office. They get a Panorex, get a good look at the teeth, good look at the upper and lower jaws. And these are the condyles here. We always, for a TMJ standpoint, look at the joint space. You can see this condyle here has severe degeneration, and there's no joint space. This one has very little joint space and remodeling of the condyle on the left side. So we have bony changes, then we go to the CT scan, and we can look at, define the bony changes more specifically. And you can see in this sagittal view how just deformed and degenerated this condyle is there. So when we have hard tissue changes, we need the CT. We also need the CT scan to get a 3D reconstruction and sometimes a medical model made that helps in our decision-making process and help us treatment plan. And we will get the medical model to build a custom prosthesis. And finally, for imaging, we have we sometimes need to look at the soft tissue. We need to see exactly what this articular disc is doing. And so you can see the classical MRI is done in open and closed views, and you get a static view of the joint and what the articular disc is doing. So the MRIs, when they're done, they're good studies, but they're very long, and they're not sometimes they're not diagnostic due to motion artifacts. So we looked at 95 of our latest MRI studies, and a clear 30% had on the official report that it was not diagnostic due to motion artifact, or the patient couldn't go throughout the whole procedure. So what would be more ideal? So what would be more ideal is if you had an imaging study that included motion. And that's what you want to see anyways. You want to see the actual functioning of the disc and the joints. And so, this is actually not a new idea, but nobody uses it. And so we took it upon ourselves to work with the MRI research team and a physicist to come up with our own protocol. And this is our first go at it. You can see it's a little choppy, but gives you an idea. And then this is our second generation, and we're getting closer. to what we want to see. So we can see the disc reasonably well. We can see how it gets deformed as it goes forward. So what we want to do is working with the physicists and neuroradiologists. We're very lucky to have a well-funded MRI research center at the VA, and we want to take 10 normal subjects and 10 deep TMJ patients, characterize the functional differences between them with the dynamic MRI, and then ultimately we want to be able to mainstream this so that it's not so difficult to look at two static views and try to figure out what's going on. We'll have a dynamic. So okay, now we've assessed all of the components, so we got to figure out what's the whole picture. And so the answer to that obviously is as varied as each individual patient is. And you can have an internal derangement with muscle hyperactivity. You can have internal derangement, degenerative joint disease, and muscle hyperactivity. So it all depends on what the patient presents to you. But looking at each individual component allows you to see that they're involved or not. And the reason I divide it up like this is because we have specific treatments for each piece of the pie. So I can intervene for this piece of the pie or this piece of the pie, and I know what I can offer the patient. So I'm going to start with surgery. I'm going to start with some of our surgical options, looking at internal derangement where the articular disc is not in the right place. And there's a variety of surgeries that have been used in the past. There's arthroscopy, obviously not surgery, steroids. There's unilateral intraoral vertical ramus osteotomy. There's disc repositioning. Tends to not work very well. There's what's called a Fossa Eminence prosthesis, and I'll show you a case of that. And then for degenerative joint disease, there's basically one surgery and it's total joint reconstruction. And you can either do that with a custom or stock prosthesis. So before you get there, you got to make sure that surgery is right for the patient, of course. You need to classify the level of pathology. For us, there's this classification called the Wills classification. It goes from 1 to 5, with 5 being really bad. You want to make sure that there's a lot of pain going on, a lot of dysfunction. You want to make sure the patient's medically and psychologically able to undergo your surgery and the post-op care. And you want to give conservative treatments a try. You want to see if you can delay the surgery for as long as you can. So here's a case. I'll go through a custom prosthesis for a total TMJ reconstruction. This, and as I go through the case, I'll sort of try to point out some of the things on the history and physical that she presents with that we look for to know what's going on. So she's a 55-year-old woman. She had breast cancer. In 2010, she was treated with chemoradiation. And on a follow-up PET CT, it was found that she had some hyperactivity, some increased uptake in her right temporal region, and that was worked up, and she was found to have severe bilateral joint disease. And so she presented to us. She was referred to us for management and treatment. On her clinical exams, her maximum size of opening was 25 millimeters, and we always have them open their jaw slightly, move it to the right, move it to the left. They're called lateral excursive movements. Those should be 6 to 8 millimeters. Hers were about 3. And she was slightly tentative palpation on the right joint. Her other past medical history included anxiety, migraines, depression, and degenerative joint disease in other joints, and PTSD. Work at the VA, a lot of my patients had PTSD. So this is a kind of a typical VA patient, believe it or not.
Is she on Viagra too?
She could be, yes. She should be. Then they have the female Viagra now, right? So this is her Panorex, okay? So she's missing a lot of teeth. This person's been through a lot in her life, you can tell. This joint over here is deformed, and there's no joint space. And this joint over here is also deformed and shows a degenerative disease. Look at the CT scan. What do you see here? There's no bone there, right? So she's got a bony dehiscence in her right fossa. And so this was actually looked at. The neurosurgeons were consulted. They weren't totally excited to do anything. So we were left to deal with it. And you can just see on the sagittal views how there is indeed an interruption in the bone. Sometimes you'll see something on the CT scan and it won't quite make it to reality, but this did. There was really a hole there that she had gone to with her condyle. And you can see that's represented here. So a little bit about degenerative osteoarthritis. So it's the most common disease affecting the TMJ. It affects women more than men. In our population at the VA rate, we have more men patients than women patients, so our numbers are always skewed. But in the general population, that's completely true. Symptomatically, you get jaw muscle fatigue, stiffness, tiredness. So basically what happens is the articular cartilage gets nutrition from the synovial fluid, and you get changes in the synovial fluid, which influences the metabolism of the cartilage. And there are many hypotheses about what is the triggering event, whether it's mechanical, chemical, or inflammatory. But essentially what you get is end up with proteolytic degradation of the cartilage, and that leads to bony changes given enough time, where you get osteophyte formation, sclerosis, and deformation. And so the two go hand in hand. Internal derangement or malplacement of the articular disc and osteoarthritis are totally related. When you get changes in the synovial fluid and the cartilage surfaces, the sliding properties of the disc change, and it gets pulled in ways that aren't healthy, and that ends up with laxity. And when at some point when the patient opens and the disc is forward, it gets stuck because the sliding properties are different and the tissues are lax. So it happens over and over again, you end up with an internal derangement. So for degenerative joint disease, for osteoarthritis destruction or other things, the indications for a total joint reconstruction are severe arthritis, not responsive to other things, recurrent fibrosis or bony ankylosis, failed tissue graft, be it a rib graft or some other type of graft, previously failed alloplastic joint reconstruction, and then loss of vertical mandibular height or occlusal relationship attributable to bony resorption trauma, developmental abnormalities, or pathologic lesions. And so alloplastic TMJ reconstruction has sort of a long and varied history. Starts out in 1840 with this John Carnican. He did a gap arthroplasty for somebody who had a bony ankylosis in his TMJ, and he stuck a block of wood in there for some reason. Not quite sure how the patient turned out, but that's what he did. 60s and 70s, they got a little more sophisticated. Christensen created a Fossa Eminence made out of cast vitalium, and then Kent and Hines made a Proplast Teflon-coated condyle ramus unit that was turned out to be disastrous for a lot of patients. And then Henry and Wolford first used Techmedica, which is now TMJ Concepts, which currently makes our joints, and they have a titanium, high molecular weight plastic fossa and mixed metal condylar ramus unit. So the advantages of alloplastic over, say, autogenous reconstruction is you get a lack of donor site morbidity, occlusal stability, because autogenous grafts can have variable resorption rates. You can immediately function with the alloplastic prosthesis. You get early range of motion and then early improvement in diet and speech, things like that. There's a decreased risk of ankylosis from heterotopic bone. Doesn't take as long to do, and you can do things like correct a retrognathia if you do it bilaterally. You can move the lower jaw forward and position your custom joints and to keep that stable. So when you're talking about alloplastic joints, I said there's stock and custom. A couple of the advantages of custom is that you have a freedom of design. If you're missing part of the mandibular arch, or for some reason you lose the mandibular angle, you can extend your prosthesis. You can design it to support a fibula, and you can design it for holes for suspension for muscle and sutures. Disadvantage of the custom is that it has this titanium backing that will often get integrated to the bone. Dental implants are made out of titanium. Same sort of problem that happens there. These are metals and materials like any other material. They have a failure point, and they have a certain risk of fatigue and fracture because of that. And there's an increased cost because you got to get a CT scan and have a medical model. So over the stock prosthesis, it costs more. And there's possibly a problem with particulation of the high molecular weight plastic component of the Fossa Eminence prosthesis. So back to our patient. This is her medical model that got made. Her occlusion got scanned in, and it got married to the medical CT. You can see that's why it sort of looks like it's in a different piece, but it's exactly what it should be. This is where the design of the ramus condyle unit is, and this is where the Fossa Eminence will go. If you look from a bird's eye view, you can see that hole. And so they designed the prosthesis so that it would cover that and protect the things that lie above. And so the patient was taken to the OR. Her disc was removed. She got a condylectomy. I'll go through the surgical steps in the next case more thoroughly, but basically she had the Fossa Eminence prosthesis placed. She had the condylar prosthesis placed, and then this is how the condylar prosthesis articulates with the Fossa Eminence prosthesis. And again, our PanRx shows exactly the relationship. There's the Fossa Eminence, or the condylar ramus prosthesis, and this is the Fossa Eminence. And now I'll go through a stock prosthetic case, and I'll go through the surgical steps more closely, just to give you an idea of how we do it. So this gentleman, you would laugh if I told you what his real name was, but Obama has the same position. He's a 60-year-old. He's had a couple of years of increasing bilateral TMJ pain. He's been on a trial from Loma Linda for conservative treatment, including night guards, Motrin, soft diet, some physical therapy. Yet, despite the conservative treatment, his symptoms were getting worse. On exam, his showed that his maximum size opening was only 25. He has some joint noises on the left more than the right. And then when we first saw him, because a lot of our patients come from far away, we try to do something for them, and then when they're there, we gave him a Kenalog injection into the left joint. Got some temporary relief, and the next time he showed up, we did some Botox. And I'll talk a little bit about that at the end. But otherwise, his past medical history, he has hypertension, PTSD again, depression, osteoarthritis, lower back pain. He's had several orthopedically related surgeries, including a total shoulder, C-spine fusion, and lumbar work. This is his intraoral pictures. This is an occlusion only a mother could love. So he's got class 3, so these are the upper teeth, and so these should actually be in front of the lower teeth. But instead, they're 5 millimeters behind. He's a 5 millimeter, negative 5 millimeter overjet. And he heavy restorations, and there's several missing teeth, which you see on the PanRx here. And you can see, looking at the joints, they're pretty much cracked too. They're degenerated on both sides, very little, if any, joint space. So he's got a surgical problem as well. When we look at the CT scan, here's some subcondylar cysts, remodeling and degeneration of the joint. You can see some bird beak and even a little osteophyte right there. Now you can see the same thing here on the other side, subcondylar cysts. Degeneration and remodeling of the joints. And so we took him, this is a stock prosthesis, we did the left side, came back 6 months later, and we did the right side. I'll go through the process. There's 9 steps to doing a stock TMJ reconstruction. First one is we make a preauricular incision and a retromandibular, submandibular incision. We sort of curve it to access the joint up top. Access the mandible, obviously, on the bottom. So we dissect very carefully down to the condylar neck. We use condylar retractors to isolate the condylar neck. When we're dissecting down to the condyle, we generally have to tie off the superficial temporal artery, because it's usually in our way. And then we have to be very careful when we're making our osteotomies. The middle meningeal is the most commonly injured vessel that can bleed profusely, and the second one is the posterior deep temporal. And you see, I'll talk about it, our osteotomies, but we want to make sure to have the upper preauricular incision and the retromandibular submandibular incision open, because if we're working in a hole, and if we get a bleeder that we can't control, we have to be able to tie off the external carotid. And that's best done above the angle of the mandibles. Has been shown to be more effective in controlling the IMAX bleeding. And so here it is. This is a hole. And so this is our condylar retractors around the condyle. It's a little bit blurry because the camera's focusing on the retractors, but you can see the malformed condylar head here. This is the fossa and eminence over here, seen diagrammatically there. And then we do our osteotomies. So we do two osteotomies. So the first one we do is we make an osteotomy across the condylar neck. We get the condyle out of the way, and that gives us a little bit of room to operate. We usually take the disc out at that part. And then we will access the mandible after that and make our second osteotomy. Everybody use this instrument here? No? Yeah? So it's kind of nasty. For years and years, that's what we used to make the osteotomy cuts. And every time when we'd let a resident cut, we'd all sort of hold our breath a little bit and wait for the bleeding to happen. So does anybody know what this is? So if you're cutting bone or anything you don't want to cut, like soft tissue, nerves, vessels, buy one of these. This will cut the bone, but it won't cut the soft tissue, the vessels. So our sphincter tone has gone greatly down with this instrument. And we had it all along. Neurosurgery bought this 2 years ago. We never knew it. But it really is a lifesaver. It's worth the cost of admission, which I'm sure is probably $200,000. And so the reason is, this is the middle meningeal artery, and it's actually worn a groove right next to the condyle. So we're making a cut, and that artery is living right there. So when it bleeds, it bleeds. And this other one's a mesenteric artery. So we're surrounded by vessels, and that bone scalpel really makes our life a lot better. So this is after the first osteotomy right here. We take the condyle out. See these little fragments of the lateral pterygoid there. This is the coronary process. So we believe that the patients get to post-operative function when we take out the attachment of the temporalis muscle. And this is the sigmoid notch, and we're trying to be about 5 millimeters below. If we go any lower than that, we risk injuring the inferior alveolar nerve. We've done that once or twice. And now, since this is a stock prosthesis, this is a stock case, we need to change the anatomy to fit the stock prosthesis. So we usually take a reciprocating saw, where now the bone scalpel, take off the eminence, and then we smooth it down, nice and flat. And then the stock kit has 3 sizes of Fossa eminence prosthesis. We figure out which one works, and then we place it horizontal to fit the horizontal. Deviation of angle could risk not opening very well, or chronic dislocations. And there it is intraoperatively. So we always need to have 4 screws into this to hold it. Sometimes we're lucky with this bone, it's nice and thick. Sometimes that bone above the fossa is very thin. We struggle for screw space. So we've already opened up the submandibular incision to have the lateral surface of the ramus and exposed, and before we put the condyle prosthesis in, we need to stop and do our intramaxillary fixation. It's given, unlike a custom prosthesis where we position everything beforehand, the stock prosthesis we rely on where we fixate the occlusions. So that is where the joints are going to be set, where the teeth want to come together. So this is actually probably the most important part of the surgery, getting the occlusion right and making it stable. Because when we go in the mouth, we're unsterile, we have to re-glove them down, and then we'll take a look at the condylar implants. We take a look at the ramus and the angles. Sometimes this is a little too bony. We need to smooth it out again to flatten it for our flat prosthetics, which are here, which from 55 to 45. Figure out which one works, and then we place it. And you can see we want it sort of in the posterior. We want it kind of at an angle like this, so when a patient opens, you get some pseudo translation. And this is the condylar unit in place. You can see these little scratches down here that we actually had to smooth off the inferior border there to make that fit well. Almost lastly, we put a fat graft in. So we harvest a fat graft from the abdomen, about the size of a quarter. Most people ask us to take more, but we stop at a quarter. And then, so the fat graft, quite a while ago now, somebody, Wolford and Harris showed that it decreases the rate of fibrosis and heterotrophic bone formation and improves mobility. So that's why we do it, and we do it for every case. There's just a small surgical scar that's pretty, doesn't have too much coincidence. And then after the surgery, or right before the patient wakes up, we release the fixation. We encourage the patient to start stretching in 48 hours. Like today, if you get a knee replacement, they're working with that night in bed. And then you want to get physical therapy as soon as you can as well. And so this is how that patient turned out. So he's now has bilateral stock prosthesis. You do have to be careful in the immediate post-operative period. These people will dislocate because now they have no muscle control of how they open and close. They have to learn that over time, so we leave these arch bars in. These arch bars are not traditional arch bars, they actually just screw into the bone. They're a little more stable than traditional arch bars, and they don't tear up the gingiva like traditional arch bars. So we use these quite a lot for the TMD case. We use elastics to help train them to open and close. So now I want to move to where the bone's okay, but now the disc is the only problem. So we have internal derangement. So one of the solutions to that has been to remove the disc and place a Fossa Eminence prosthesis. And this young lady came to us. She had 2 years of increasing pain in her left joint. Despite her smile on her initial presentation to us, throughout the entire exam, she was pretty much in tears because she couldn't deal with pain in raising 2 of her young kids at the same time. Her maximal incisal opening was limited, her lateral excursions were limited, she was tentative palpation over the joint. You can see on her dentition there's evidence of increased occlusal wear, so she probably grinds and bruxes to a certain extent. She's in ortho treatment to help fix her bite, which isn't quite there yet. She's got sort of a crossbite here, not perfect yet. And this is a phalanx yet again. Her joints actually don't look too bad. Her joint space on the right looks good, but actually you look over on the left and she's got a very narrow joint space. So we're suspecting internal derangement on the left. We get the MRI, and indeed on the closed view, her disc is anterior. And they'll always say it reduces when the patient opens, but that's not because the disc moves, that's because the joint head moves underneath the disc. And so in internal derangement, we get this situation, and the joint is working off the retrodiscal tissue, and it can make it very painful and difficult to live. So I went through our choices for her. She didn't want a lot of downtime. She didn't want to have her teeth wired shut, so we chose to do a Fossa Eminence prosthesis. And you can see here, this is the condyle. This is with the disc removed. We put a distractor on our angle, and we pull everything down that lets us have access to the disc. This is the Eminence and Fossa here. This is the disc. It sort of looks like an overbaked clam. feels like that too. You can see that it's a little bit folded over, perhaps, and a little thin in the middle. These are the strands of the lateral pterygoid that was left over. So with custom fossa eminence prosthesis, the advantage is that you're taking out a bad disc. You can see how shiny this is. This is a shiny, smooth surface that is designed for the condyle to articulate. So we had one made for her, I had a medical model, and this is what it looked like in situ. This is what it's supposed to do. It's supposed to make it more comfortable, and it did. It works for her. You can see this is the PA ceph. It's a little bit of a metal potato chip in there, and the lateral ceph, and again the panther. See how it lies. Problem is, so you set up a situation where you have two unlike materials. You pit bone versus steel. And looking at this stress strain curve, metal is far stronger than bone. Although bone has some elastic properties, it behaves more like glass. And over time, bone's going to win. And that's what happened in this patient. So we did the exact same surgery on the right side for this patient. Took out the disc, put a fossa eminence prosthesis there. And about a year later, he came back to us with increasing pain and dysfunction. And you have to look really close. It's a little subtle, but he's having some resorption changes on his bone. His bone is becoming sclerotic, and this situation is failing. So he was converted. To a total joint prosthesis. And in fact, we tell people this when we do the fossa eminence surgery. We tell them it's basically a setup for a total joint replacement. In fact, when we look at our numbers, 21 people that have had a fossa eminence prosthesis, almost half of them, 9 of them, have had have to go all the way to a total joint reconstruction. And interestingly, if we look at a time to failure, is about 3 years. So the FDA thinks this should be about 5 years. That's why they forced the company to take this off the market, and this is no longer an option. It's probably ready for sale, but nonetheless, that's where we're at. So there is another option. We usually reserve this option for a younger patient, but we instead of moving the disc or removing it, we do an intraoral vertical ramus osteotomy, and we move the condylar head underneath the disc. We bring the head to the disc. This young lady, 22 years old, she had orthodontic surgery of the cervix, so she had Bimax surgery. She was class 2. She got an BSSO advancement and a LaForte setback. And what happened was that with the BSSO advancement, these are the cuts here. And so when you bring the mandible forward, the distal segment is on a different plane than the proximal segment. But yet they're fixated together rigidly. So you bring these two segments together, and that pushes the condyle out laterally. And that happened on both sides. And you can actually see the lateral poles of a condyle pushing through her skin. She was in a lot of pain. So what did we do for her? We did an intraoral vertical ramus osteotomy. We take an intraoral approach. We have an IVRO saw. And we make a cut through and through from the sigmoid notch to the angle. And we let this condyle take a more natural, unstressed position. And you can see on the lateral ceph, we keep this segment lateral. We actually put a little suture in down here and tack it to the periosteum to make sure it stays lateral. And after this, she got good relief, but she swore she'd never want to do it again until she came back and asked us to do the other side because they had the same problem. And there's our osteotomy. And she's currently healing from this surgery we did 4 weeks ago. So I spent like the last half hour telling you all the good things about alloplastic TMJ reconstruction, right? So what's the bad part of it? Well, I think the bad parts of it are pretty obvious. You produce the shape and function of the masticatory apparatus because you remove all the native tissue. The alloplastic joints, muscle, and ligaments aren't going to be attached to the metal or plastic. So that's never going to be the same. And then additionally, you have a potential for allergic responses. You have potential for loosening of screws or fractures of the components, and limited future imaging due to scatter. So what would be better? Well, I think everybody knows that stem cells are the next big thing, and we've been fortunate enough to have an early collaboration with this group from Columbia. They've grown various components of the TMJ apparatus in the lab, and you have some animal models growing. And so what we want to be involved in the clinical trial and actually putting some of these adult stem cell derived organs, if you will, into the human. So I'm excited about that. So let me switch gears from the surgery to what we do in the office. So in the office, we can specifically target things like muscular pain and then other stuff, other chronic pain. We can tackle as well. And so things we can do in the office are Botox injections, steroid injections with our arthrocentesis. Some people do arthroscopy in their office. Hyaluronic acid injections. There are various pills and patches that people use. Physical therapy we always use for our surgery patients, but we can use them for our non-surgery patients as well. There's night guard or splint fabrication, and we find actually combinations work the best. So if we do Botox combined with a night guard, that's often enough to get people by so where they don't actually need surgery and they can live their lives. And so pills and patches. So there are centrally acting pills like Flexeril, tizanidine, gabapentin, Lyrica. Honestly, I try not to prescribe many of these. I try to get their primary care doctor or a pain doctor to do it because I don't really want to manage them. But there are some peripheral things like Lidoderm patch, which is a patch you can put on, and it works really well, but it's a patch that people have to wear on their face, so it's a little intrusive. Flector patch is the same sort of thing, but with an NSAID. And then, of course, just NSAIDs. So next we do intra-articular steroids. So of course, steroids, they have an anti-inflammatory effect. And the fluid volume that we inject in there may actually serve to break up adhesions. And you can give it at the end of arthrocentesis or arthroscopy. So just a little idea how we do it. We go 1 centimeter in front of the tragus, 2 millimeters down, and sort of go in at an angle, find the arch, kind of bounce off the arch a little bit, and slide into the joint space. Get it nice and numb first so the patient doesn't scream in pain and punch you. And mix 1 cc of chemical fluoride with 1 cc of 0.25% Marcaine. As you inject it, the patient will feel pressure in the joints, and even their back teeth may not touch for a couple of days. And so that's when you know you've hit the right spots. So steroids, they take 3 to 5 days to take effect. They can last 3 to 4 months, but sometimes they can last longer than that. Problem with steroids is that when it does wear off, you need to do it a second time. It usually doesn't work, so you got to go to something else. And when we do have to go with something else, and the patient wants to stay on the conservative side, there's hyaluronic acid. So we'll inject hyaluronic acid into the joint space at least 3 times. Probably try five injections separated by a week or 2. The problem with this is there actually has been no clinical trials for any joint showing that it actually works better than anything, or actually is an improvement. But there is a lot of evidence that is not a clinical trial that says it helps. So we do it and we find it generally helps. And it's kind of designed to give longer treatment, longer term relief compared to steroid injection, and that's been our experience. We don't have a lot of numbers with it, so we really haven't quantified it. So it can be either considered as a next step steroid or first line treatment. So now my favorite, Botox. So we actually use Botox for just about everybody. If you walk into our clinic, you're going to get Botox. I say that kiddingly, but not really. So everybody knows Dirty Harry Callahan, right? So he has the 44 Magnum, the most powerful handgun in the world. So meets Clostridium botulinum. So botulinum toxin is one of the most powerful toxins in the world. And it really is. So there's 4 Botox A's on the market. We tend to use onobotulinum toxin made by Allergan. I think they just got bought out. Occasionally, Botox A will not work, or will stop working, and we'll switch to Myopla. But that's not very often. And of course, the reason Botox works so nicely and so effectively. All right, good. All right. All right, so the reason Botox is such an effective toxin is one, it has a highly efficient uptake mechanism and delivery of the light chain. And the light chain is a catalyst. So it gets used, it functions over and over again and never gets used up. So the Botox A hits the SNAP 25, and Botox B hits the synaptic ribbon or the vamp, and it just chews it up as fast as it can come out, and it never gets used up. So that's why it's so effective. And of course, what it does is creates a temporary chemodenervation, both in striated muscle and in myoepithelial cells. What do we use it for? So we use it for bruxism, clenching, situations where there's hyperactive muscles and mastication. We use it in cases of internal derangement or degenerative joint disease where there may be muscle splinting because the joint itself is painful. We use it both in surgical and non-surgical patients. If we can get the surgical patients before the surgery, we do it. If not, we'll do it afterwards. We use it for relief of migraines and for aesthetic purposes of our residents. So how it's done. So not a very complicated armamentarium, a couple of syringes, a couple of needles, a little bit of saline, and the Botox itself. We do 4 cc's of saline and 100 units of Botox. So cut the area with an alcohol pad. We palpate the muscle, we have them clench, and we make some marks on the thickest part of their muscle, the bulge of the masseter and their temporalis, the anterior portion here. Then we'll do 20 units, we do 10 units of spots, so 20 units in the temporalis and 30 units in the masseter. If you use this stuff, 4 cc's into the bottle, don't shake it, you'll break up the protein and you'll wonder why it didn't work. You just want to very gently swirl it. When don't you want to use Botox? When there's an infection around the injection site, when there's no hypersensitivity to Botox, certain neuromuscular disorders, and some people have personal religious beliefs about human serum-derived products. So when you inject it right, people look and there's actually no systemic exposure. Like the Botox is undetectable if you inject it correctly. But remember, it is a really powerful toxin, so never be complacent. And so, take your needle, go down the bone very gently, lift up 3 to 5 millimeters and slowly inject. We use either a 27 gauge or a 30 gauge needle. Does it work? Well, we looked at our data, 5 years, 71 patients. 80% of them got benefits. 20% or so found there was no benefit. Got a bigger benefit, people that drugs, people that use their muscles and mastication more. But even the people that weren't in that category still had benefits. And then interestingly, we found there was sort of a delay in the cognition of when these people appreciated the benefit of Botox. So based on their follow-up, some people came early, some people came later, and that was not by design because this is a retrospective study. It was just how it happened. If we asked them too early, we were more likely to get a no benefit response than if we asked them later. And we know by experience that some of those people in the group where there was no benefit got a benefit because they come back for more Botox in the future. So it does help them. Sometimes it just takes at least 5 weeks, if not more, for them to appreciate. So conclusions: Botox works over well, decreasing pain with people with various TMDs. That's predicted to have a positive effect in people that brux and clench, people that muscle splint because of their joint spurt, people with anxiety-driven psychiatric problems. And when you ask somebody, make sure whether Botox works or not, make sure it's after 6-8 weeks or so.
They tend to have any problems with chewing?
Yeah, so they definitely, I always warn them that they will feel weaker. So if they eat a steak or something like that, their jaws will feel weaker. And I tell them that's the point, that's what we're trying to do. And so most people, they don't worry about that.
When you inject one side, you're denervating that side, but then the other side is taking over. Is there a muscular imbalance?
We usually do bilateral.
I see.
Yeah. Occasionally somebody will have one of the muscles that will hurt, just specifically hurt, and we'll do that. But it really doesn't cause any imbalance specifically.
One of the things we do a lot of Botox to develop muscles domestically. One of the things we found is that maybe do it 3 months, but then do it 6 months, increasing it to 12 months. Are you finding that as well?
Absolutely. So the muscle gets atrophic. We have patients that come over and over again, and I've got a career development grant that I submitted. Didn't get funded, but I submitted looking at the timing. So we've got EMGs, we're going to do ultrasounds, and the muscle becomes very atrophic, but yet the pain comes back. And if you Botox it, the pain goes away. So so I'm writing a couple of papers about why, where else is Botox working if it's not at the neuromuscular junction? Probably gets centrally as well. And so I'm grant to look at that.
So migraine.
Yeah, same thing with migraine, absolutely. Yep. Yeah, there's probably a central activity to it.
Is there a swing back to using implants? Because about 25 years ago, implants were pulled off the market because they erode into the middle cranial fossa.
Yeah, so the technology has gotten better. And the two designs I showed you are the best that are out there, and they're safe. There isn't 25, 30 years of experience with them. There's about 25 with the stock, and about close to 30 with the custom. So the technology is acceptable now, and it doesn't do the things that the ProPlast implants used to do and the others used to do. So I think right now that's the best solution. But I think in the future it would be great to take some fat, grow some bone from your stem cells, and then implant that. I mean, that's ultimately, I think that's where it's going to be 20 whatever years from now.
In a lot of your pictures, you show that the posterior dentition is absent, so you have a tendency of overclosing.
Right.
But implants in the posterior mandible.
Yeah. So that gets tricky. I mean, when you see somebody edentulous and they complain of joint pain, that's why it's because they're overclosing. And that's an issue with a lot of our patients. The vets, a lot of them socioeconomically are not doing all that great, and they do have they're missing a lot. Occasionally, we will offer to rebuild them to a certain extent, and we do. And we'll give them dental implants as well because they're our surgery patients. But yeah, that's an issue that does contribute.
I presume the answer is it doesn't work this way, but can you ever preserve the joint and just deal with the condyle, or do you almost always have so much damage to the joint that you can't?
I mean, there are people that do like arthroplasty of the condylar head, and it always gets worse. Like I said, there are people that actually try to take the disc, either with arthroscopy or with direct surgery, and that typically always fails because the way it works, the way the joint works and the disc works, it doesn't. it can't withstand what you try to do with it. What you try to do with it fails against its function, essentially. That's why, there's only two things that really work well is the joint replacement and arthroscopy. There's not really a good surgery anymore for the internal derangement other than the IVRO that I showed.
Step 8 of your joint replacement surgery, you're talking about putting in the autologous fat. Do you think some of the improvements came from stem cells within the fat? Is anybody looking at sort of
Nobody looked at that, but that's
platelets, or-
curious. It's possible.
Is there any plasma-rich platelet research right now, like in research?
Yeah, I mean, and then you got, along with the stem cells, you have like some growth factors and all that good stuff. We have a colleague in New York that he takes people that have painful alloplastic joints, and he with arthroscopy will put that in, and that actually improves them. So maybe there is something, there are stem cells or growth factors in there improving it, and there very well might be when we do our total joint suite up front.
I don't know if you see many of these in your practice, but how much do you think TMJ is a problem in children and teenagers? And how do you approach those differently? Is there a different approach?
Yeah, there
for
is. So the
that
growing
age versus
patient,
children?
yeah, absolutely. In the growing patient, I mean, we're more focused on autogenous grafting and distraction. So you don't want to put one of these in a growing patient. And unfortunately, not a lot of kids go to the military and make it to us. But yeah, that's generally the thought process.
Physical therapy, we have a lot of patients who try to manage conservatively.
Yep.
One, because we don't have a surgeon down here that does this, and secondly, because about 90% of it's more muscular or other things.
Sure. Right.
So trying to find good physical therapists to do head and neck physical therapy, there's maybe 7 of them in the whole Bay Area.
Yeah,
That's
no, exactly. I mean, we don't have one in our hospital. We will pay people to go on the outside and find a physical therapist that does do it. It's challenging, yeah, absolutely. It's a problem, and there are people that specialize in it. Matter of fact, there's chiropractors that specialize in it, and so it is a problem. It's not really taught in physical therapy school very well, and so have to specialize.
It's a poster, and fortunately, we have 2 right in the area, but
Yeah.
it's really, really hard to get people in there, especially if their insurance doesn't cover
Right,
it.
well,
or,
exactly,
It's just
yeah.
like a nightmare for us. Is that something that we could encourage the physical therapy schools?
Yeah, no, I mean, or you could get a physical therapist interested in it, and if they could specialize, yeah, they wouldn't be able to close their doors, yeah.
Right.
Have you had any experience with the newly developed tiny ear mold called Cerazon or Cerazen from the Life Sciences? It's a little impression that's made for the ear canal that stents the TMJ for minor
Right,
TMJ.
I've heard of that.
Yeah.
Yeah,
Have you had any
yeah.
experience with that?
No.
I mean, it looks promising.
You're
very,
right, I did see that the other day.
very
and,
simple and.
I don't know a lot about it,
Yeah.
but you never know.
My second question is that have you had patients with complete dehiscence of the TMJ with the TMJ inside the ear? I've had a few patients.
Inside the ear?
Yeah, the joint actually hits the eardrum when they open and close.
I mean,
And no matter what we do to reconstruct that ear canal wall, I've tried it multiple techniques.
Yeah.
It just the TMJ is so powerful that joint will break through everything. So have you had to do any reconstruct?
not that problem.
I know what I did with
I mean,
that.
you saw the case where we had the dehiscence in the fossa and the
Right,
temple
but this is a patient has dehiscence into the ear canal and his eardrum, the joint hits the eardrum and
Wow.
he hears it loudly and it hurts.
Right. No, I haven't seen that.
I tried to reconstruct that ear canal 2 times with all different techniques. I put him in IMF
Yeah.
and nothing worked. So finally we did a condylectomy and he's been happy ever since.
Yeah, that sounds like it.
So what do you think about unilateral condylectomy in some of these patients?
That's fine. And some patients, let's say like osteoarthritis necrosis patients where everything is dead, will end up having to do a partial mandibulectomy or hemimandibulectomy, including up to the condyle, disarticulating the condyle. And some of those people, we let them swing and they do okay.
That's right.
When you let them swing, how often do you wind up with contralateral TMJ issues?
A lot, yeah. But you sort of, at some point, especially with osteoarthritis necrosis patients, not left with a lot of choices. But that's the thing with just doing one-sided jaw joint reconstruction, is that the other side makes up for what this side's not doing, and we tell everybody this is a bilateral thing. Most of the time they're going to need the contralateral side done. We tell them right up front that that's the case.
So right now I have a patient right now, some of the residents may have seen that patient with me that has a mass in the ear canal, was referred to me for exostosis surgery, but upon examination it is the TMJ. It's in the ear canal, it's no exostosis.
Yeah.
And this patient's condyle is in his, and it blocks his eardrum and gives him a little bit of conductive loss.
Right.
And debris sometimes gets trapped. So we're managing conservatively, but my only option for him would be to do a condylectomy.
Yeah.
So do you have any other options for him?
I mean, you could do that and do a prosthetic joint replacement. You can design the joint replacement so that it has a back wall where that ramus, the condylar head doesn't go back. You could do that. You can do a lot of design options with these prostheses to a limited extent. The FDA is always there, and the world company always worries about that.
Okay, thank you.